Hi guys, hope you are all doing well and that this transition is going smoothly for each of you. I know there's a lot going on right now, so I'm really trying to communicate with you and let you know what's happening as far as our class goes, what to expect, anticipate, and I just want to let you know that my expectations for how the class is going to go and maybe expectations with some assignments and projects are definitely going to be a little bit different given the current scenario. That said, we are moving into chapter 12, which is cardiovascular health, and this is the last chapter prior to taking exam 2. I am still waiting for confirmation as to how I am going to approach exam 2, so I'm working closely with the testing center to kind of really identify what the best means of getting that exam done here in the next couple of weeks. Chapter 12, cardiovascular health. This is, it's all about cardiovascular disease, right? And you're going to hear me refer to coronavirus. And that's because the most recent research coming out about the virus is indicating that those at the highest risk are those with underlying cardiovascular issues. Now this could be hypertension. We talked about how hypertension is kind of a silent killer, and many times you're not even aware that you are hypertensive. And so we're talking about individuals with hypertension, high blood cholesterol, hyperlipidemia, an already established form of cardiovascular disease that they are aware of. Maybe they've already had some sort of cardiovascular event, or they also could have diabetes. So you might hear me referring to coronavirus because this is what the most relevant research is showing, that one of the reasons this is spreading is because we know that CVD affects nearly 83 million Americans in the United States. We also know that it's obviously not just affecting the United States, but it's affecting other countries as well. And we're going to look at what some of those risk factors are for CVD, and I think that you'll really start to see the correlation between all of these countries, things that we have in common, and why maybe coronavirus is kind of getting a foothold and really going to work here. So CVD includes heart attacks, chronic chest pain, also known as angina, stroke, and heart failure. CVD claims one life every 40 seconds, and that's per the American Heart Association. And this is largely due to our way of life, our American way of life. We've talked about how, in general, Americans are sitting a lot more, so a lot more sedentary lifestyle. Maybe that's just being on smart devices. A lot of the workforce these days, it's sitting. You're sitting at a desk instead of standing. A lot less laborious jobs available these days. And many Americans are unaware of the warning signs of CVD. So, as I just mentioned, hypertension or even diabetes. There's many that are living a pre-diabetic lifestyle or have diabetes are unaware of the links with cardiovascular disease. Cardiovascular disease often starts with damage to the cells that are lining the inside of the blood vessels, and then inflammation plays a key role in the CVD progression. So really physicians are actually looking at something called C-reactive protein with a lot of patients. Why they're looking at the C-reactive protein is it's an indication of the amount of inflammation in the system. So if something's going on, there's plaque formation, there's hardening or damage to the cells that are lining the inside of those blood vessels, then inflammation is present in the system, and that C-reactive protein level will increase. And so physicians look at that as an indication of whether or not there's inflammation present, and then what is the greater picture because of that level of C-reactive protein. Heart attacks often occur at mild to moderate coronary blockages, so we're talking 70% or less of a blockage, but what happens is the plaque that's forming inside can actually rupture and then allow that clot formation to occur, and that is potentially what is blocking the vessel and then ultimately leads to a heart attack. There is a paradigm for prevention and treatment, and there's three different stages of this paradigm. The first one being primordial, and this is really the prevention of risk factors. So if you know that cigarette smoking is a risk factor, which we do, then preventing that risk factor would be a primordial approach to prevention. So that would mean stopping cigarette smoking or quitting chewing tobacco, for example. The primary stage is really treatment of the risk factors. So a risk factor has already caused damage. We know there's already issue because of the risk factor. This could be a hereditary risk factor as well. But let's say that the risk factor is diabetes, for example. We're going to try to treat the diabetes, make sure that the blood glucose levels stay at appropriate levels, healthy levels. For instance, if it's hypertension, then we're going to try to treat hypertension. Same thing with hyperlipidemia, making sure that those levels are within those healthy ranges to ultimately treat the risk of a cardiovascular event occurring. And then the secondary is prevention of recurrent cardio events. So this tells us that something has already happened, those risk factors really took foothold, and they were able to cause some cardiac event to occur. And so secondary prevention is really just trying to prevent any recurrent cardio events. And you know that you're at a much higher risk of having another cardio event once one has already occurred. So what are those risk factors for cardiovascular disease? We know that there's both non-modifiable and modifiable risk factors. So non-modifiable, we know that men have a greater risk of CVD than women. Men also have heart attacks earlier in life. And if we look at age right below that, the risk for CVD increases with age, men being about 45 years old and women being more closer to 55 years old. And I'm going to touch real quickly here on coronavirus because this occurred originally in Wuhan, China. And we usually look at China as being a pretty healthy country. Lifespan is longer if we compare it to the American lifestyle. But what we did see is that, what the research is reporting anyway, is that these men, a lot of them were men that were dying, and they were over 40 years old. And while they may have had fairly healthy lifestyles as far as nutrition and eating a balanced diet goes, most of them are heavy smokers, smoking tobacco several times a day. And so that being a risk factor, if we look down there, modifiable risk factor, smoking. So I think this is one of the reasons, and based off of the research, this is one of the reasons why the majority of the individuals that were dying in Wuhan were men who were in their 40s, and that's linking again to an underlying cardiovascular risk for coronavirus. Additionally, we have race. CVD is higher among Mexican American, American Indians, Native Hawaiians, and African Americans. A family history. This is really important. It's really important to know if you have a grandparent or parent even that has a history of CVD, because that tells you that you need to start looking at those risk factors, those modifiable risk factors even sooner. So having your blood pressure checked, having your cholesterol checked, making sure that you're not pre-diabetic, those things become even more important at that, knowing that family history is definitely playing a role. And then modifiable risk factors, smoking, as I just touched on, high blood pressure. Okay, this is where we're going to see that if there's resistance in the system for the heart trying to push the blood out, or the heart just has to work really hard to push that blood out in general, then the heart muscle itself is going to thicken and become stiffer over time, which means it's going to be less efficient. It's not going to work as well. High cholesterol, as your cholesterol increases, so does your CVD risk. So we know that cholesterol can be affected by age, sex, hereditary, and then also diet, physical activity, obesity, right? We know those ones. Prediabetes, diabetic are also being diagnosed with diabetes, and then diet. So we know that the foods that you eat can affect these other modifiable risk factors, and so it becomes really important to be watching what we're ingesting, whether that's watching our sodium levels because of being diagnosed with hypertension, or watching the amount of cholesterol that we're ingesting due to hyperlipidemia. So if we look at tobacco use, 71 million Americans are tobacco users, and 13.6 million college students are also tobacco users. This is a pretty large number, really. I think this number probably has increased in general. These statistics have probably changed a little bit due to the use of e-cigarettes now, also vaping. We're seeing that vaping is playing a big role and causing a lot of respiratory changes as far as the lungs go. So I think these statistics probably changed a little bit since I've included them, but still kind of shocking information. So for instance, if you're an individual who is packing or is smoking 1 pack a day, you're 2 times more, you're at twice as likely or a higher risk for having a heart attack. If you're just cigarette smoking in general, we're looking at being twice as likely to have a stroke, and then the risk of heart disease in general is 2 to 4 times higher. So what are the effects of smoking? We know that they damage the lining of the arteries, so we just touched like the second slide about how this cardiovascular disease is really the damaging of the lining of the arteries. We see decreases in HDLs, which are those high density lipoproteins, and those are the good guys, right? Those are the good cholesterols who are working to take that unused cholesterol that's wanting to build up in those arteries and transport them back to the liver to be used or excreted if necessary. We also see that we have raises in triglycerides and those low density lipoproteins, right? So this also is what we would call double negative. We're seeing decreases in our HDLs, the good guys, the good cholesterols that we want to increase, and we're also seeing an increase in those low density lipoproteins, which are the bad guys, the ones that are, if they're not used, they're being built up within the arteries themselves and causing that plaque to form, and therefore we have hypertension. We see increases in blood pressure and heart rate, which is obviously interesting because most people smoke because they need it to relax, right? To reduce stress. It's a way of managing stress. But really, if we're trying to manage stress, we would want to reduce our blood pressure and our heart rate, make those things come down, and that's how we manage our stress. But really, smoking causes the opposite to occur. And then we know that it reduces oxygen availability. If we have oxygen if we're deprived of oxygen, then we know our working muscles and tissues are not getting what they need. Same with bones. We have a lot of things that the calcium that starts to get leached from the bones, a lot of things start to happen that ultimately cause the breakdown of our system. Low bone mineral density, muscle atrophy, etc. It causes platelets to stick together, which leads to clotting, and then the development of fatty deposits in the arteries, also really important to know. High blood pressure or the hypertension, so these are important numbers here, these categories. So for being within a normal range, we would hope that systolic would be under 120 millimeters mercury, and for diastolic under 80, so 120 over 80. That would be ideal. I think I mentioned in class that really these numbers have started to come down. We have other organizations that are now recommending like 115 over 75 is ideal, but I think if we have someone who is pre-hypertensive, and we do get them down into that 120 over 80 range, and that's awesome. Any step is really going to help. Excuse me. We know hypertension really results from an increased output of blood by the heart. So again, that heart is having to work really hard because it's already been damaged. It's having to work really hard, or because there is a resistance to the flow in the arteries, and that resistance is going to be because there's already plaque formation. There's a little bit of a blockage that's occurring. And then we see that there's the scarring and the hardening of the arteries, and that is going to make them less elastic, and that's going to further increase blood pressure, because when we have that heart pushing, we're hoping to have a little bit of give within those arteries to allow for expansion, contraction, as that blood comes through. And so when we don't have that elasticity, then we're going to see that we have even higher blood pressures within those arteries. Looking a little bit more at those ranges, we get really nervous with somebody who is hypertensive. Stage 1 would be 140 to 159 over 90 over 99. And I'm going to be honest, there's a lot of people like that. There's a lot of older individuals who on a daily basis have a blood pressure within that range. Taking their blood pressure several times a day, the doctor wants them to keep track, maybe 3 to 4 times a day, to see if the medication they're on is working, how their system is responding. If it's not working, they're going to move on to something else. And sometimes people will go through several different blood pressure medications trying to find one that fits them, because they all have a list of associated symptoms. So maybe some of them are causing you to swell up, right? You're having edema, and so that can be really uncomfortable depending on where that edema is occurring. Some of them cause neck pain, jaw pain, whatever it is. There's a whole bunch of different symptoms that could occur by taking these medications. And then the other thing is that one might feel great. You might not have any associated symptoms with taking it, but it might not actually be lowering your blood pressure to a point where the actual physician wants to see it. Most physicians want to see that your blood pressure is really getting down into those 120s, over 80s, or lower for diastolic. And if you're not getting there, they're likely to change your medication again. In stage 2, 160 over 100, that's very nerve-wracking. If you go into let's say you go into a clinic for a procedure or a hospital for a procedure and they see that number, they're probably going to send you immediately to the ER, because those are very scary values. They're thinking that a cardiac event could happen or is happening. So they'll probably have you take a stress test to make sure that your heart and your heart rate can handle whatever might happen for activities of daily living or for the test that or procedure that you're about to undergo. Some of the, if we look here, I really like this picture because it shows us really what that atherosclerotic artery could look like. We see the beginning of a healthy artery, how open it is. We have lots of room for that blood flow. And then over time, as we see the progression of that plaque buildup, we see how much that artery starts to narrow. The LDLs, ideally, we would like to see that they are low, right? We want to see that they're ideally 100 milligrams per deciliter. That would be ultimate. That's not, I think that's a really hard number for a lot of individuals to achieve, though, especially older individuals. But those LDLs, they shuttle the cholesterol from the liver to the organs and the tissues that require it. And so, but if they don't get used, if we're taking in too much and it's still being shuttled to those tissues, but we don't need it, and we have too much, we have this buildup, and then they don't have anywhere to go, so they just start building up in those arteries. So ideally, again, we would like to see that your LDL levels are about 100 milligrams per deciliter. If we look at the HDLs, as I mentioned earlier, their job is to shuttle the unused cholesterol back to the liver for recycling. This could be used for good. Ultimately, they could perhaps be used for energy depending on what's happening. But we would like to see that your levels of HDLs are closer to 60 milligrams per deciliter, if not higher. So what about physical activity? We know that engaging in physical activity is kind of going to thwart off all those things that we just talked about, those risk factors. So it's kind of that magic bullet against heart disease. We know that it decreases your blood pressure. It's going to decrease your resting blood pressure and your resting heart rate as well. It's going to increase those HDLs, going to maintain a desirable weight, right? We want to stay away from being overweight and obese because we know that's going to put additional strain on the heart. It's going to improve the condition of the blood vessels and prevent or control diabetes as well. It helps to maintain those healthy blood glucose levels that we've talked about a lot. So some risk factors for obese, or continuing with risk factors for CVD, we see obesity. And death from CVD is 2 to 3 times higher in obese individuals. So we're talking about a BMI of higher than 30. Now keep in mind, BMI is one of those things where, again, it does not take into consideration what lean muscle mass is, and we definitely have athletes who would be considered overweight or obese at times based on what their BMI is, although we know that they are just have a ton of lean muscle mass, but maybe they're shorter stature, and so it makes their BMI look pretty high. Excess weight is going to increase the strain on the heart by contributing to high blood pressure and high cholesterol. We also know that the more fat mass an individual has, additionally, I guess the more that the heart has to work, it has less muscle or force-producing muscle or lean muscle tissue, then it is going to have to work a lot harder with the lean muscle tissue it has to move all the fat mass that it has. So it has to use everything it has to actually move that amount of mass because the majority of it is not force producing. So if we take an individual who is only let's say 8%, 8% body fat, the rest of their system is going to be, well, obviously we have the skeleton, we have things that aren't actual force producing, but if we take the amount of lean muscle mass that they have, it's probably a fairly high number. And so they have a lot of lean muscle mass to actually work against whatever fat mass that they have and that they need to move around. Fat that collects around the abdomen is going to be more dangerous than fat that collects around the hips. So that's that android versus gynoid. This is why that we see males being at a higher risk for cardiovascular disease at an earlier age. That's because they're going to have a little bit more weight. They're going to carry it up higher in their chest, that android body type, rather than a gynoid body type, or kind of a pear shape that we see a female being shaped as. Was noted, I think, early in one of the earliest slides that females are going to be at a higher risk for cardiovascular disease around the age of 55. And a lot of that also has to do with the fact that that's when they're going to probably start or be postmenopausal. Keep moving here. So what are the major risk factors that can't be changed? Heredity. We know that those who inherit a tendency for cardiovascular disease may have to work harder than others to prevent it. Aging. 70% of heart attack victims are about 65 and older. Being male, we already talked about that. Ethnicity. African Americans are at the highest risk for CVD. The C-reactive protein, I did mention that earlier. High levels of CRP are going to be indicative of cardiovascular disease as well. So again, those are things that we can't change. Major forms of CVD, we have atherosclerosis, right? We talked about the thickening and the hardening of arteries. At the brain, and the heart and other organs are deprived of blood and the oxygen it carries, the results can be deadly. So if we have the blockage of a coronary artery, that's when we have a heart attack. But if we have a blockage of a cerebral artery, that's considered to be a stroke. And moving here, this is an example of a coronary blockage or a coronary thrombosis, and that would be the result. The result would be a heart attack. So over half Americans that have one attack will have a recurrent attack. We also refer to a heart attack as a myocardial infarction, and it can be symptomless, or the symptoms can be very vague, very, very mild. And so some people aren't even aware when they're having a heart attack. So an attack that's specifically caused by a blood clot is called a coronary thrombosis, which is, again, a heart attack has occurred. And I think it's also important to note here that sometimes we use the term heart attack and sudden cardiac arrest interchangeably, but that's not actually accurate. A sudden cardiac arrest is actually when there's been a malfunction of the heart, and it's usually an electrical malfunction. So something with the beating, the heartbeat that's supposed to occur that is not, or for some reason the heart has just stopped beating. But a heart attack is actually due to a blockage or to a clot that has occurred. Here are some of the possible heart attack symptoms. We have angina pectoris, which again, that's the pain in the chest. It's a signal that the heart isn't getting enough oxygen, and a lot of people have a threshold as far as how high they can get their heart rate up before they start to feel that angina. And so it's important to kind of steer clear of being in that, or steer clear of that threshold so that they aren't feeling pain. Arrhythmia is a disruption in the electrical impulses. Controlling heart rhythm or irregular heartbeat could have somebody go into ventricular fibrillation, or a quivering of the ventricle could occur, which would obviously result in ineffective pumping of the blood. And then other things that we might see are pain in the arm, the neck, the jaw, difficulty breathing, excessive sweating, nausea, vomiting, and ultimately we could see the loss of consciousness. So a stroke is also called a cerebrovascular accident, and it occurs when the blood supply to the brain is cut off. And we know that if the brain cells are deprived of oxygen for more than a few minutes, they do die. And this is really going to make a difference in the overall impact of this stroke on an individual. For instance, if an individual has a mini stroke, things weren't deprived for very long of oxygen, but depending on how old you are, other things that have maybe, if there's any atrophy already in the brain, it's really going to make a difference in what happens to the system ultimately. So if you could have a mini stroke and lose use of your right arm and have to work really hard to get any use back into your right leg, for instance, if you have a left brain stroke. If you're younger and it's a mini stroke, you might not have as big of a response. It might be the symptoms and the damage might be a lot less than if you're an older individual who is already dealing with issues. Okay, I want you to, if you can, to take some time and just watch that video on YouTube, because it's neat in that it shows you exactly what's happening with a hemorrhagic stroke versus an ischemic stroke. An ischemic stroke is actually the most common, and that's when a blood clot causes the blocking of the artery, versus a hemorrhagic stroke when we would have the rupture of the blood vessel, and that blood would leak into the brain tissue. So if you can, it would just give you a really good visual image of what's happening during the stroke. Okay, congestive heart failure. Damaging of the heart's pumping mechanism is due to, ultimately, hypertension, heart attack, atherosclerosis, viral infections, okay? Rheumatic fever, that would be rheumatic fever. We don't see that happening very often anymore, but that could be due to rheumatic fever. It could be due to not treating strep throat appropriately, or scarlet fever, which again we don't see scarlet fever anymore, or it could be due to a birth defect, because some infants are born with birth defects that automatically diagnose them as congestive heart failure. So how do we manage heart disease with nutrition? Ultimately, whole grains and high in fiber have been shown to help reduce cholesterol. Lean protein that includes a healthy amount of protein without the cholesterol is what we're shooting for. No more than 7% of the total calories, your total caloric intake for the day, should come from saturated fats. Ideally, ingest 2 3.5-ounce servings of fish per week to get those omega-3 fatty acids. Fruits and vegetables, ultimately, to reduce LDL cholesterol, and then low sodium is going to help decrease that hypertension. These are the diets that I mentioned earlier, but I moved them here because I thought, since we're talking about managing with nutrition, the therapeutic lifestyle change diet recommendations. This is for someone who has high cholesterol, and the goal here is to make sure that saturated fat is less than 7% of your total caloric intake. So they're really focusing on making sure that you're getting whole grains, things that are full of fiber to help reduce the LDLs, to make sure that if you're not ingesting as many LDLs, that the system can go ahead and use what it already has, and then it can begin to increase the HDLs to reduce the buildup of plaque in arteries. And then the DASH diet eating plan is for individuals with hypertension, so high sodium, really focusing here on how to reduce sodium intake and make sure that we're focusing on intake of potassium, calcium, and magnesium in particular. Managing heart disease with physical activity. If someone has any cardiovascular signs or symptoms, they should really be cleared by a physician before they start to engage in physical activity, just to make sure, especially let's say they have angina, they experience angina, the doctor might recommend that they stay below 10 beats of their threshold for angina pain, to make sure that they're not pushing it too much, and that whatever they do is not going to lead to a larger cardiovascular event. Aerobic prescription decreases the heart rate and blood pressure at rest and at a given submaximal workload, so we know that if they reduce their heart rate and blood pressure, then the heart doesn't have to work as hard, and that's what we're shooting for, especially if they've already been diagnosed with cardiovascular disease. If we can reduce the amount that the heart has to work, that is a primary goal. And we also see that there's improved ability to take in and utilize oxygen. We talked about VO2 max. And that's what a VO2 max is gauging, right? Your ability to take in and utilize the oxygen that you're taking in. So if you become better at that, we know that the system is becoming more efficient, and that the tissues are getting what they need. And that means that these individuals can engage in any type of physical activity longer at higher workloads without getting fatigued. And decreases in body weight, fat stores, total blood cholesterol, triglycerides, and LDL cholesterol. All these things are just going to work to reduce the amount of stress and strain that are put on the heart. Resistance training prescription, we want to reduce sarcopenia, so the loss, right? The loss of muscle mass. We want to favorably modify coronary risk factors, reduce hypertension, improve our glucose uptake, so the intake of glucose that we have, to be able to utilize that by the tissues, increase our insulin sensitivity so that the insulin that we do have can take the glucose and take it to the tissues that are needed, and those receptors can actually work to receive that glucose and put it to action. And then diabetes and our basal metabolic rate. So if we have more lean muscle mass, we're going to see an increased basal metabolic rate, which is going to allow us to burn more fat at times of rest. And then decrease the cardiac demands during daily activity. If we have more muscle mass, again, the heart does not have to work as hard, because we have the muscle mass to complete the work at a much lower workload, or at a much lower rate. We're going to briefly look at the influence of medications. So we have aspirin, statins, beta blockers, and angiotensin converting enzyme, or our ACE inhibitors. So aspirin works as an anticoagulant, and really this can make or break the individual's physiological response to a heart attack. It can really determine if an individual lives or dies. If somebody is having a heart attack and they have aspirin, and they take aspirin, it can really, really help to reduce the damage on the heart. And if there's not aspirin around, it's not available, that individual might suffer a lot more damage to the heart because they weren't able to stop or slow the heart attack from occurring. The anticoagulant is going to prevent the blood platelets from sticking together, and then that obviously is going to help to lessen the chance of clots forming and the occluding of the narrowed coronary arteries. And it's recommended for myocardial infarction, stroke, coronary artery bypass surgery, balloon angioplasty, stable angina pectoris. So a balloon angioplasty is when they have to actually go in and insert a balloon. It's kind of like a balloon. They blow it up and that opens the arteries to allow blood to flow. And it has been shown to decrease the incidence of reoccurrent myocardial infarction by about 25% in patients with known cardiovascular disease. If we look at statins, I like that, Big Mac with big statins, please. It's used to treat high cholesterol levels. You want to block the cholesterol production in the liver, and then in doing so, that's going to help to draw cholesterol from the bloodstream. So again, we're going to block more production of cholesterol in the liver because we're already taking in enough. We're getting enough from our diet that we don't need our liver to keep producing as much as it has been. And so what that's going to do then is the system is going to draw the cholesterol from the bloodstream. So if we have less cholesterol, blood cholesterol, then it's going to reduce our hyperlipidemia or our blood glucose level or blood cholesterol levels. I've been talking for a really long time and I'm really starting to feel it. So, decreases in total cholesterol and LDLs by up to 50% with use of statins. A lot of individuals are taking statins. This is a very commonly prescribed medication to help control blood cholesterol levels. And the important thing here is that because it's altering the function of the liver, it can cause increases in liver enzymes, which could increase or result in liver damage. So individuals who are taking statins, their physician is often going to monitor those enzymes, those liver enzymes, test them every now and then to make sure that they're at a healthy, normal range. And then rhabdomyolysis, that's gonna is a symptom oftentimes with taking statins, and that's muscle pain, right? A lot of muscle soreness, muscle pain that isn't. It's not being relieved. It's not muscle pain, muscle soreness from a hard workout. It's just there. It's staying there. So trying to kind of control or manage that can be difficult sometimes when you're taking statins. Blood pressure, if we look at beta blockers, the beta blockers work to lower blood pressure. They reduce the heart rate, and they're going to actually there's going to be a threshold that's set for that heart rate. So perhaps your heart rate isn't going to get above 120 beats per minute. That means that if you're working out and you're trying to use beats per minute for example, to know what intensity you are working at, let's say you're working at 70% of your max heart rate at 120 beats per minute, you're not going to be able to use that because we would not anticipate your heart rate ever going above that because the beta blockers are not going to let it happen. And so it's important that if you are taking beta blockers or someone you know is taking beta blockers, that they used rate of perceived exertion instead. And so if the goal here is to inhibit the sympathetic nervous system, if the sympathetic nervous system is inhibited, that's how we have that decrease in blood pressure and that reduction in the heart rate. It's actually really interesting. I've worked with individuals on beta blockers before, and I've prescribed exercise for them. And if you have them put their hands on the heart rate monitors on the bike or the treadmill or whatever it is, it'll just bounce all over the place. It'll say like 85, and it'll jump up to like 115, and then it'll jump down, and it just jumps all over the place. It's like it can't really figure out what's going on. So again, you have to work with that individual to know what their rate of perceived exertion is, so you know how to properly prescribe exercise. ACE inhibitors, this is the angiotensin converting enzyme. We're trying to inhibit that enzyme, and it's it's going to constrict the blood vessels and cause the body to retain salt. And if it inhibits that angiotensin activity, it will then decrease blood pressure. So it's inhibiting the activation or that enzyme activity of angiotensin converting enzyme. If that is reduced, then it's going to help to decrease what that blood pressure looks like. It can reduce cardiovascular events by 20 to 25%, which these are large numbers. That's why individuals are prescribed these things, is because there's actual research that is showing that there's a significant impact. Blood pressure, if we look at diuretics and calcium channel blockers, diuretics are in water pills, which help to lower blood pressure by increasing urine and salt output. And then calcium channel blockers are going to work to relax the vessels and increase the supply of blood and oxygen to the heart, and thus reducing blood pressure. So those are a couple other options for individuals who are looking to lower blood pressure. The last thing I would say is just to, if you can, take a couple seconds, and watch this Oprah show. And it's an old one, to be honest, but I think it's interesting because it's about a woman who's, I think, 39, and she had a heart attack, and she really didn't recognize what the symptoms were at first. She didn't really understand what was happening, so I think it's just an interesting perspective on it. And then I've also included this, something that we were going to do in class, but we won't now. But this is a very interesting approach, what the research is showing as far as a natural control to cardiovascular disease. So if you have a few minutes, check those things out. My throat hurts because, hopefully not because of coronavirus, but just because I've been talking for a really long time. So I'm going to call it quits here, and I hope you guys are taking care, and I'll be in touch with you. Thanks.